أهلا بيكم. أنا هاني نعيم استشاري السكر والغدد الصماء، بكلمكم النهاردة من بوخارست من مؤتمر النيورودايات، مؤتمر الجمعية الأوروبية للسكر، ويسعدني ويشرفني أن يكون معايا النهاردة أستاذ الدكتور بروس بيركنز من كندا. Good morning, Professor.
Good morning.
Okay, would you please introduce yourself to the people of Egypt?
Yes, absolutely. But first, if you don't mind, I just want to say thank you for inviting me to this podcast
Thank you for coming.
and to congratulate you on all of your advocacy work and expertise in diabetes.
Thank you,
Really
Professor.
appreciate it. So I'm Bruce Perkins. I'm an adult endocrinologist and clinician scientist at the University of Toronto. I direct a diabetes center called the Leadership Sinai Center for Diabetes and oversee clinical research. Though I have research throughout diabetes, my main focus is in type 1 diabetes.
Okay, so type 1 diabetes is a very hot topic always because of its sensitivity, especially with the families of the patients who have type 1 diabetes. Okay, will you first tell us what is type 1 diabetes?
Yeah, it's a little confusing because there's multiple forms of diabetes. The most common is in order to understand type 1 diabetes, I have to describe type 2 diabetes. Type 2 diabetes is the condition that's mostly associated with overweight, obesity, and more sedentary lifestyle. Though a lot of people can get type 2 even without those things. There are certain ethnicities that have a higher risk. So it's a little bit complicated, but it's the kind of condition where we can begin with a stepwise treatment, diet, exercise, certain types of medications, and maybe eventually insulin. Type 1 diabetes, when it happens, the immune system has decided to get rid of our insulin-producing cells. It happens out of the blue. Through no fault of one's own, just like type 2 happens through no fault of one's own. But people need insulin immediately, essentially for survival. They die without insulin. This is type 1 diabetes. So is that
No,
fair?
that's
It
fair
can
enough.
happen at any age.
Good point.
It happens in childhood a bit or much more than type 2 diabetes does, but it can have its onset essentially at every age except for the first months of life, like the first 6 months of life. We don't see type
Okay,
1
but
diabetes.
you can see someone with new onset type 1 diabetes at the age of 75.
85,
Okay, so it's not a big deal. It can happen.
for sure.
Okay, so then comes the next point. When people find out their son or daughter or child have type 1 diabetes, they tend to starve them. Is this of any value?
No.
Thank you.
So for sure not. The idea is to be able to eat, a diabetes diet, but essentially a normal healthy diet, but with enough insulin replacement to allow that healthy normal diet to be associated with target blood sugars. Not exactly normal blood sugars, but close to normal are target blood sugars. Now, it's true that if someone eats less, they can have more normal blood sugars, but the risk is that we restrict food so much that people aren't healthy. They're losing weight, they're getting sick, they don't have the energy that they need.
Okay, so that's a very good point. Next point is, are there any specific restrictions for type 1 diabetes?
I suppose there are, but I'll tell you the whole philosophy of my clinical work and my research is that someone with type 1 diabetes can live out their life the way they would have if they had never developed type 1. For example, I'm not sure if this is what you meant by restrictions, but it used to be that if you had type 1 diabetes, you couldn't fly a commercial airplane. That's no longer the case because there have been we now have technologies and much better insulins that can help people control and be aware of their blood sugar moment by moment.
So this is a very, very valid point. Okay. First of all, one word answer, yes or no.
Okay.
Should a person with type 1 diabetes, or is it possible for a person with type 1 diabetes to use premixed insulin, fixed doses?
So this is not recommended. I guess if it's a one-word answer, it's no.
Thank you. Okay. Second question. Should a person with type 1 diabetes learn how to match their carbohydrate intake with their insulin doses?
Yes,
Okay,
that's the whole drama and the work of type 1 diabetes now.
okay, wonderful. Third point, is it possible to play sports with, I mean, athletic competitive sports with type 1 diabetes?
Yes, there are
Okay.
great examples of competitive
Olympians.
athletes with type 1
Olympians.
diabetes. Oh my gosh, yeah. There's nothing about type 1 diabetes that impairs someone's ability to take part in sports. Now, it requires some organization around blood sugar control. It's work, but it's definitely possible. And
Okay. How can it be possible?
how can it be? Well, first of all, type 1 diabetes doesn't affect muscle. You know, like people's
Okay.
muscle function is normal as long as they're getting good nutrition, etc. But how I do work with a lot of athletes, so you know, we tend to actually basically type 1 is treated either with multiple daily injections of insulin, and we have great insulins today, or with an insulin pump. And when we use an insulin pump, because there's so many more benefits to someone who's struggling, we try and use what we call hybrid closed loop,
Smart pumps.
where the pump is working with a continuous glucose sensor that is worn on the body, and the pump hears about the blood sugar every 5 minutes and adjusts the insulin in response. But the person with diabetes still has to tell it when they're eating. That's why it's called hybrid closed loop. The closed loop is adjusting some of the insulin, but they still have to tell it about food. And the other reason it's called hybrid is because they have to tell it about exercise in advance of exercise. So the athletes we work with that we use hybrid closed loop pumps with, we work together for them to put them into an exercise mode or algorithm starting a good hour and a half before exercise. And then it can help adjust insulin during and most importantly after exercise to help prevent low sugars and high sugars.
Okay. So basically what you said was, in other terms, is for a person, for an athlete to play sports with type 1 diabetes, they must have continuous glucose monitoring. It's not an option.
Yeah, I would say, I mean, you can never say never, never say always. There are
but
people who do well, but essentially I would say
most
yes,
cases,
a
okay.
continuous glucose
And
sensor.
preferably a smart insulin pump or a hybrid insulin pump, because it may be very, very difficult to do it without such technology.
Yeah,
What would
that's
you say?
true. I would say if you had to pick one of the two, I would start with the continuous glucose sensor. And then, yeah, for all intents and purposes, a pump has really helps people through the stressors on a blood sugar, like the extreme exercise, etc.
Okay, wonderful. And as we are talking about new technology, okay, many people come to me asking, can I use Ozempic or Mounjaro instead of, or Trulicity instead of multiple daily injections?
So definitely not instead.
Okay.
And generally it's not, okay, there have been studies using these types of drugs in type 1 diabetes, slightly older versions, and now there are studies using the newer versions for type 1. It helps with blood sugar control to some degree, not a huge amount. Definitely helps with weight control. So realistically, even though it's not quite approved in type 1 diabetes, a lot of people with type 1 do struggle with gaining weight over time because it is tough using insulin therapy. And this is one way that can help control weight for some. So most clinicians keep an open mind to using them if the patient can. And in fact, even in Canada where I am, our clinical practice guidelines are asking clinicians to keep much more of an open mind to these adjunct to insulin or add-on to insulin
But they're
medications.
adjuncts, not replacements.
No. Insulin
Definitely.
is required for survival in type 1 diabetes. So if we're going to use any of these drugs, it's meant to help that insulin, not to replace it.
Okay, wonderful. Now, next question. What about stem cells?
Yeah, stem cells. So the idea, wouldn't it be great, like when we use an insulin pump, like these hybrid closed loop, the pump is responding to a blood sugar and altering how much insulin is being given. Wouldn't it be amazing if you could just have the insulin producing cell put back into the body and it respond to the blood sugar?
It would be a dream come true.
So they kind of work. Like we can take these insulin producing cells from people who've donated their pancreas. So people who donate their pancreas, sadly, they have to die first.
Okay.
And then they've agreed to have their organs donated. And they can extract these. It's called islet cell transplantation. And then they're implanted into someone who then has to take immunosuppression because it's someone else's cells. So their body's designed to kill them. And on top of that, they have type 1 diabetes. So their bodies are designed to kill insulin producing cells. That was the problem in the first place. So they have to be on immunosuppression. But unfortunately, those cells, when they're extracted from someone else's pancreas, they're fragile and they're not so strong. So one transplant's never enough. You need 2 or 3. And even at that, most people aren't off of insulin. The goal are for people who are really struggling with severe hypo or low blood sugars, where month by month they're being admitted to hospital or losing consciousness. They can do much better with those transplants because the transplant doesn't replace all their insulin, but some of it. So it makes their diabetes management a bit easier and helps prevent hypoglycemia. So now, wouldn't it be great if we could have much healthier cells? That's where stem cells come in. So there's been amazing research that's moved forward by using a specific, we call them cell lines. It was developed at Harvard, this guy named Doug Melton. He took stem cells that came from an embryo, and those stem cells, he then guided them through the process to become insulin-producing cells. In fact, the whole, what we call islets, it has insulin, but also other hormones that help influence insulin. And then they get infused into the liver, and the person also needs immunosuppression, so drugs that keep the immune system from attacking those cells. And now we have great proof that those cells work.
Yes, but for
People,
how long?
well,
But for how long?
Good
Like
question.
with the trial, which was published, okay, we're talking about like it was like 80% needed a second dose after 1 year. There were 2 deaths inside the trial out
Yeah,
of
so
20
this
or
is-
12, I think.
yeah. So what you're referring to
Okay.
is a specific trial. It's by a company called Vertex. They
Yes.
developed those
Genetic-based things.
those
Yes.
Doug Melton cells they took from Harvard, and so they all actually got one dose of cells. They didn't need repeated doses, and they had 14 people who now receive them for over a year, and all but 2 of those people are completely off of insulin. Most come off insulin the first 6 to 9 months. The cells need a little time to kind
To
of
adjust
deal
and
with the
start to
shock.
work,
Yeah,
okay.
exactly.
Okay.
But they do work. But now, some people have had 2, even close to 3 years of follow-up, and they remain insulin independent, but we don't know for sure that they're going to stay insulin independent, meaning not needing injections forever.
Okay.
But the idea is that because the cells are available, you don't have to wait for someone to donate a pancreas. It means that if they do fail, they could get another infusion. But right now, we don't know about how long they will last.
Okay. But,
And you are right that there were 2 deaths. So the big worry is this immunosuppression. My patients with type 1 diabetes are leading full functional lives, are healthy. We're helping them with insulin therapy. The average person with type 1 wouldn't want to take on the risk of lifelong immunosuppression. Some people have had to because, for example, let's say they developed kidney failure and they needed a kidney transplant. They're already on immunosuppression. I feel like right now that has to be a focus to help those people who now could benefit from the stem cells, but also not add much risk to what risk they've already agreed to take on through their immunosuppression. But for the general type 1 population, not yet. The 2 deaths, okay, one of the deaths, so to me that's worrisome because there are only like 14 people.
so we're talking like 15% of the study population died.
Yeah, this is unnecessary to say, but you said that there were repeat doses. It turns out the first 2 people got a half dose and then they got an additional half dose That was kind of the initial piloting of this. One of those people did die, and it's very convincingly from reasons that had nothing to do with the study and nothing to do with immunosuppression. But the other person who died of a kind of brain infection that no question had to do with the immunosuppression. So that is a bit worrisome. So, we don't want everyone with diabetes to get this. There has to be the right risk ratio, meaning they've been struggling with their diabetes by having severe hypoglycemia.
Let me ask you, if you were to choose between insulin and immunosuppression, which would you choose?
Yeah, so I think most people will choose insulin. Now, if you're already on immunosuppression, you've already made the choice.
Okay, if you are on immunosuppression
because of a kidney transplant,
whatever. Yeah. Okay, well, it is so. And then, so as I'm taking the let's say the unfavorable medication anyway, so why not benefit till the end? Okay,
that's the one situation. But the second situation is that if I'm someone on insulin who, despite trying to do his best with all these technologies in insulin, and still getting severe hypoglycemia where I'm losing consciousness regularly or needing help from someone else to treat my low
this
sugars.
This isn't the norm. Like, this isn't...
it's not the norm, but it still happens. So I'm just saying, and those are real people who need real help. And so for them, that's a worthwhile option to think about some form of cell-based, either a clinical islet from a donated pancreas or a stem cell derived.
But let's be real here, because all day long I get people telling me that stem cells are like being on shelf. I want stem cells, so my doctor will just put his arm out and get the stem cells and inject them, and voila, that's it, go home. Okay, this is what's being advertised.
Yeah, well, to start with, stem cells for insulin replacement aren't even available yet. And there's a few other details about that trial we didn't talk about. One is that not everyone can get the cells because those cells that were developed happen to be from a specific blood type, and you have to be of specific blood types to get it. So immediately it's less than half of people who can even get it. But they're working on it. They're going to have cell lines where it doesn't matter which blood type you are. So let's put it this way. Right now, they're not available to begin with. It's still in research. And secondly, even if it were available now, not everyone who would choose it amongst those who have severe hypoglycemia or already have a transplant would be able to get it because they're limited by a specific blood type compatibility.
Well, anyway, so to wrap this up, first, I really thank you for today. Second, we first talked about what's type 2, what's type 1.
Yep.
Okay, went through them. Then we went through the modern insulins and how things are better, the philosophy of treatment of type 1 diabetes, which is basically insulin replacement. Then we went through the use of the injections used for weight loss in type 1. Okay, we talked about that. Then we talked about the new technologies like continuous glucose monitoring and insulin pumps, hybrid closed loops. Then we went through pancreatic cell transplantation. And then at the end, we talked about stem cells. They look like a good option for the future, but still not here. Thank you, Professor. And I believe the people of Egypt will thank you for your time.
I'm so grateful to you, Hany. Thank you. We could have talked about 100 things. And also, you won't know this, but because it will be edited out, but during the interview, my own insulin pump, because I have type 1 diabetes as well, started alarming and we had to pause. So it all, even in the best of situations, things don't work out perfectly with diabetes, but I'm very grateful for what we have. Oh, 100%.
Manageable.
100%.
Thank you, Professor.